started on the session today, everyone. So welcome to St John of God Murdoch Hospital. My name's Matilda and I'm the Public Relations Officer here. So today we're lucky enough to be joined by Dr. Jaques Pretorius. So he's a consultant gynaecologist and obstetrician here at Murdoch. He's been here for just under 10 years now, but he's been working as a gynaecologist and obstetrician in Perth for over 20 years. So we're very lucky to have him to talk to you all today. And I'll hand over to Jaques for the session. Enjoy.
Hi. Morning, everyone, and thanks for joining us. There's someone still coming in at the end. So today I'm going to talk a bit about heavy menstrual bleeding, heavy periods, and more specifically on the minimally invasive treatments that we have for that and that I can offer patients here at Murdoch. I will broadly chat on other things, but we will talk more with regards to the minimally invasive treatments. A little bit about me, as Matilda just said, I'm a generalist obstetrician gynecologist. I'm also a dad. That's my daughter, who's crazy enough to be following in my footsteps. My son, who definitely won't be following in my footsteps. And my wife, who's also in the medical field. She's a school nurse, as well as works in the mental health at Hollywood Hospital. As you probably hear from my accent, I'm not from Perth originally. I'm from South Africa, did my training there. Was working in a private practice setting there and wondered what was going on. Why is everyone leaving? What am I missing out? Everyone is coming to Australia. One of my colleagues went over to Bundaberg and I went to go visit him and did a tour of Australia and decided I think we should come and live here and see what it was like. Started down in Rockingham, was in public service for a while and then realized I love Perth and we've stayed and stuck. A little bit about periods, a bit of high school biology, just to get an idea behind it. So we know the uterus, the important organ that really causes the most drama with regards to periods is the endometrium, the lining of the womb. That builds up throughout the cycle because of the hormonal effects of the ovary. It becomes thickened to a point that ovulation occurs, and if fertilization doesn't occur, that endometrium, which is tissue, has to liquefy, and it liquefies by inflammation, and that's why periods can be extremely painful. And then the blood comes out. It's not a tap, it's not a blood vessel that bleeds, but tissue that liquefies and then causes the period to occur. And this was an interesting stat that women on average will have up to 500 periods in their lifetime. What are heavy periods? Well, they really are difficult to measure. We have lots of means, pictures, weighing pads, things like that, but they are extremely, and we'll talk about how inaccurate all the measurements can be. But a normal period will be anything between 30 to 40 mils per month. Bleeding can last up to 8 days, but usually about 5 days, and that is the medical definition of it, as well as cycles that are less than 21 days. The incidence, unfortunately, is very common. We know that 1 in 5 women will suffer from heavy menstrual bleeding, which equates to almost 500,000 of women that are struggling with this at that time. And up to half a woman in their late reproductive years will have heavy menstrual bleeding. And it's a very common reason for being referred to specialists like myself. What are the causes? I'm not going to go into all of this. Suffice to say that I think it's important to try and find a cause, because if we can find a cause, we can tailor a specific treatment which will lead to a good outcome and a effective response to that treatment. And I'll touch on some of them, but we'll get to that later. What's important, and I think people struggle with the understanding of what is then heavy for themselves. And it is really a very relative term. A third of women who have normal or light bleeding will say they have heavy periods, and more than that, who actually do have heavy periods say they're only moderate. And just thinking on how much blood is coming out is also a poor indicator of how this impacts on women's lives. So we therefore know that that perception really corresponds very poorly with the actual blood loss that happens. And we've got to be looking at that impact that it has on women's lives. And we know that when you do start having long-lasting and heavy periods and you're needing to, change your protection very regularly, it can be extremely disruptive, not only to your family, to your social lives, to work, to your mood, to your daily activities. And there are good studies that have actually gone and tried to quantify the impact that this has on women's lives, that it has physical effects, the need for taking pain medication, that it has the effect on your social life, that it creates anxiety and a form of separation, and that up to half of women that have heavy periods really feel overwhelmed in that time. And we know that up to a high percentage of women that actually do then miss out on going to school and their everyday activities. And unfortunately, most women will not report this. They will not seek help. We wonder why, whether it's an embarrassment, whether it's a false belief in what this is normal. But I think it is time for us to start that conversation, to start asking about your periods, and for you guys to also open up to your GPs with regards that this is affecting your quality of life. It's affecting how you're functioning, and it is making you feel depressed and tired. I think it's important when we know that you really do need to see your GP when you suddenly see a change in your period. Periods that last more than 8 days, or periods that come more regularly, more than 21 days. And also not getting your period is not necessarily a good thing. Painful periods that cause you to stay at home, and bleeding in between periods and bleeding after intercourse are actually quite worrisome signs and need to be addressed and need to be looked at. And as I said, even though these above symptoms are important and should not be ignored, I do think it's important that you consider what is the impact of your period having on your social life other than those things that we know. And if it does cause you to miss work and social activities, to chat with your GP. And if you do think that your life would improve if you could decrease your periods, it's worth going to see your GP. Your GP would probably ask for some blood tests. They would like to make sure that you're not pregnant. They would look for possibly a bleeding disorder. I think the other important thing is to look for iron levels. And a lot of patients who are anemic or have iron deficiency don't realize that they probably are losing them too much iron through their periods every month. And that can be quite easily addressed. They probably will do some swabs to exclude infection. They will do a cervical smear, especially if it's not up to date, and they probably would send you for a pelvic ultrasound. You may be referred on, if you are at high risk for certain conditions, to have a thing called a hysteroscopy, a look inside the uterus. That's usually done by a specialist, or an endometrial biopsy, especially if you're at risk of endometrial cancers or endometrial hyperplasia, thickening of the lining of the womb. The most common causes of heavy bleeding are structural causes, so fibroids. We'll come back to that. Adenomyosis, which you might not have heard of, and uterine polyps. But in a large percentage of cases, over 50%, no cause will be found, and that's called dysfunctional uterine bleeding. And that's where one of the modalities I'll talk to you today we can really address is this thing called dysfunctional uterine bleeding. So what are the treatments for that? We will talk about hormonal treatments and non-hormonal treatments, and I'll go into each one in a bit more detail. So the good old pill, which can be used as an oral contraceptive, is actually licensed to be used as treatment for heavy menstrual periods. And it will treat the hormonal imbalances, it will regulate your periods, and in time your bleeding will get less. But unfortunately, it has not a very effective outcome, and up to 50% of them, they won't control the periods, and about 50% of patients will have quite severe side effects with the oral contraceptive. There are hormonal side effects, and it really does require you to take that pill every day, because it's not a course of antibiotics. It is something that while you're using it will decrease your bleeding, but once you stop, you will go back to your that cycle. And it may not be for all patients. Some people are contraindicated to use the estrogen. There are drug interactions with other medication. As I say, it does need daily pill taking and follow-up and monitoring required. And we know that in this study, up to 10% or only 10% of patients at 5 years will continue using the pill, that they'd chosen to go for other options, and 2/3 ended up having surgery. So they ditched the pill and went on to having surgery to treat their periods. Another hormonal kind of treatment for the abnormal bleeding is the Marina Iud. It's a small plastic frame, that's what it looks like, and it has a reservoir with progesterone in it. And that progesterone then thins out the lining of the womb, and in time, generally, women will have less periods. It can be inserted in the office, in theatre, or in the rooms. Its indications, it can be used for contraception, but it's also licensed to be used for idiopathic, is again this dysfunctional uterine bleeding. It's also, other indication is to be used in the menopause to protect the uterus when we are giving hormonal replacement therapy. The other advantage of that is once you take out the Mirena, you return back to your normal fertility. Unfortunately, it can take quite a while to work. It's not a quick fix. Up to 6 months, we would normally say to patients, and I find that a major barrier for patients is that usually in the first 3 months they have irregular bleeding, they have continued spotting, and they then ask for the Mirena out. If you were to wait, it will get better. So there is a failure rate, but in time, as you can see, at 1 year, about 1/5 of patients will have no periods, amenorrhea, and then up to almost 40% will at 5 years have no periods. And for most people, that is really a good outcome in time. And it is about 2/3 of women will have a reduction in their symptoms at 5 years. What are the hormonal options that we have? Medications like the anti-inflammatories. Remember I said that the period was actually an inflammatory response as this tissue liquefies. So using anti-inflammatories do work, not only for the pain, but also for the bleeding. And things like Nurofen or Ponstan can work. They do have the added benefit of relieving painful periods, dysmenorrhea. The problem with them is you can't use them for long periods of time. The side effect profile, gastric side effects, and again, once you stop the treatment, usually you revert back to normal. Tranexamic acid is a drug that is actually quite effective and is a useful one. It helps with that breakdown of the tissue and the clotting and the reclotting, and you can take it, but you only need to take it while you have your periods. And it looks like it's more effective than the anti-inflammatories. And it can reduce the flow in each period by up to around about 50%. But it is associated with gastric side effects, and patients who have blood clot risks potentially can't use this drug. Then we move on to what I really want to talk about today is the minimally invasive treatment. And this is again a non-hormonal treatment, and the one that I'm suggesting we look at is the endometrial ablation. There are a few on the market, but the NovaSure is the one that I use and we use here at Murdoch. It's extremely effective. It's a very short procedure. It also avoids those side effects of the hormonal treatment. And the way that it works is that it delivers electrical energy and it burns the lining of the womb. It is extremely safe, and it is definitely covered by most people's health funds. We'll come back to that, but just on the last one, then another definitive treatment then for heavy menstrual bleeding would be a hysterectomy, a removal of the uterus. It is the only definitive treatment. If your primary goal is to never see a period again, then this is the only one that will guarantee that. However, it is associated with complications as it is an invasive surgery. You do need a general anesthetic. There is a recovery period depending on the type of hysterectomy, and obviously once you've had that done, you can't have any more kids. So let's talk a bit about that NovaSure procedure. The typical candidate for it is a woman who is still having a period. She's premenopausal, but she's completed her family. Because the issue with that is we actually burn the lining, we destroy the cavity so that you are not allowed to fall pregnant after that. We do diagnostic tests to exclude abnormalities, as we spoke about, because that would rule out being able to offer this procedure, because generally this is a device that's used for women with dysfunctional uterine bleeding only. It is extremely successful. The blue bar is what patients consider success, and they can have up to, in this study they say 75%, I normally quote about 40 to 50% of women will have no periods in 5 years' time. The other interesting thing is we spoke about the amount of women that ended up with surgery that were using the oral contraceptive pill. When you use the NovaSure used, most women will end up not having a hysterectomy. So in that study there were only 8%, 3% ended up going to surgery, and 6% in that study there. It not only stops the bleeding, it actually shows increased quality of life with regards these as well as PMS symptoms. We can't explain it because it actually is not hormonal, but women who have less bleeding end up having less PMS as well if we do the NovaSure. So how does it work? Under anesthetic, we have a look inside the uterus. We normally do an endometrial sampling, a biopsy of the lining of the womb. The endometrium, as I say, that's the organ that's causing the trouble. And if the cavity is not too big or too small or any abnormalities there, we insert a wand into the uterus and we deploy a net. That net then opens up. The importance of it is that there should not be any folds. As you can imagine, folds would then create a hotspot which would burn through the uterus, which is extremely uncommon or actually impossible, because if that occurs, we can't actually push the button. So one of the issues with the NovaSure is it's only at times of deploying the net and deploying the net safely that we can say, will this work for some women? So in up to 2% of patients, we end up going to theatre, deploying the net, and we can't actually push the button. It's a safety mechanism. It's actually a good thing because the risk profile of this device is extremely safe. Once the mesh expands, it conforms to the uterine cavity. And as I say, we push a button. It's got a few mechanisms to check that mesh is well deployed, and then electricity is passed through that net and it burns up to a fixed depth of the endometrium. The net is removed, and that's what you're left with: a scarred up uterus on the inside, ovary still in place, uterus still in place, and tissue that then heals on the inside. This is what it looks like. That's what, if we were to look inside the uterus, a normal endometrium on that side, and then a scarred endometrium. Usually takes about 90 seconds to do. So what can you expect? As I say, it's done usually in a hospital setting. At Murdoch, I do them at the surgery center, which is just a day clinic in front of the hospital. It's extremely quick, and usually the whole procedure takes about 5 minutes. You might have some menstrual cramping afterwards, but most women don't experience any discomfort at all, and generally are sent home after a couple of hours and can return to normal activities within a day or two. Expect a watery discharge, as that tissue that is burnt has to slough away, but it's usually not too disruptive. Mild cramping and usually an anti-inflammatory suffices. Because we're burning, there is risk of infection, but that is extremely rare, and we normally give information sheets of what to expect and when to call us if anything was to happen. The wonderful thing with the NovaSure is patient satisfaction rates, that women will significantly report that their periods are improved. And the most amazing thing, when I see my patients at 6 weeks afterwards and they say, well, I was meant to have a period and I didn't have one, and they are extremely satisfied and happy. We also see that there's a reduction in that dysmenorrhea. As I said, once that inflammation gets taken away, the pain of periods, And that's something we can't explain, whether it's the impending, I'm going to have a horrible period that's going to be painful, that's taken away, that women then have less anxiety about their periods, we're not sure. And as I say, the satisfaction rates are extremely high. Women would be happy to tell their friends that they have no periods at all in most cases, and that they don't end up having surgery, further surgery. I think the important thing there is also to have a frank discussion with your doctor, and I have a frank discussion with the patient, is what they expect. If a patient does expect not to see a drop of blood ever again, then this might not be the right procedure for you. Then a hysterectomy may be the one. If there are other causes for your bleeding, then this may not be the right procedure. But if those are excluded, this is an extremely successful procedure. Who can't have it? I think it's important. We are disturbing that cavity, so if you are pregnant or want to have more pregnancies, this is not for you. If we think that you are at risk of endometrial cancer, that needs to be excluded, and obviously if you do have it, then this is not the procedure for you. Where the myometrium is disrupted, where you've had a previous classical, so that's a Caesar that is cut from the top to the bottom of the uterus, usually in very preterm deliveries, or if you've had a previous myomectomy, if we've had fibroids removed, and I'll come back to showing you what that means. And if the cavity is just too small. I've also seen ones where the cavity is just too big that we can't actually deploy the net wide enough, and in that way then also fails the testing that gets done. If there's infection, then we can't do the procedure. That needs to be treated at first and then can be done afterwards. There's been some studies that have compared the ablation then to the Marina. This was one study, had 110 patients. They were randomly assigned to one or the other. They all had no cause for their bleeding, and this showed in the green, which is the Marina, there was a higher rate of dissatisfied, and that's usually those women in that first 3 months that their periods just continued, didn't improve. It got better with time. 2/3 of women were pretty happy with the Marina, but as you see that the NovaSure was extremely successful in reducing the bleeding. More amenorrhea rates, this is only at say 12 months. Remember I said at 5 months the Marina does start getting up to about that percentage, and the authors did conclude then that the NovaSure was better than the Marina. What is it? After 5 years, we know that with regards to the oral contraceptive pill as treatment for heavy periods, 2/3 of them will go to surgery, and only 10% will probably still be using the oral contraceptive pill. With the Marina, half of them may discontinue, and up to 40% will continue to surgery. But with the NovaSure, we talk about a high rate of reduction as well as a high rate of satisfaction, low periods, and similar numbers of women that will not have further surgery, will be very happy with it. However, again, we talk about the hysterectomy. It is the only definitive treatment that will definitely say you won't have periods. It might be indicated in women who have other causes for their bleeding, or in women who have had failed other treatments, and then is considered a last resort. So what would this mean? This does mean that the perception of the medical treatment for it is probably overstated. We probably think it's going to do better than what we do, knowing that up to 2/3 of women it may not work for. The Marina is better than the pill, and the the tranexamic acid is also better than the pill for treatment of abnormal bleeding. But they don't lead to high patient satisfaction. I think it's important, as I said earlier on, is that trying to find the cause so that we can offer the right treatment is critical. So further testing needs to be done, but these are not massively invasive tests like an ultrasound and blood tests. However, the endometrial ablation is extremely effective in treating women who don't have a structural cause for their bleeding. So we have a quick, simple procedure. There are no incisions, no hormones, and most women will not end up needing further treatment. Any questions before I go on to the next bit? Yes?
So just when you were talking about not being eligible if you've had a cesarean, when you said classic cesarean, as in up, down.
So that's an incision on the uterus itself. that is usually from the top to the bottom of the uterus itself. It's done very rarely these days. Usually it's if you had a Caesar for a very small baby, a preterm baby, 28 weeks, where the uterus hasn't really formed. There's few other indications for that. So, yeah. And generally, if you were to have had a classical Caesar, so it's not a cut on your tummy, it's the cut on the uterus itself, the obstetrician should have warned to say, well, look, this is the case, because it does impact on further treatment that you might get. So as I said, we were talking about dysfunctional uterine bleeding. That was no cause, normal uterus. Now we go over to potentially other, also minimally invasive treatments of structural causes other than a hysterectomy. And this is a device called a MyoSure. It is a hysteroscopic, a camera that we put through the cervix into the uterus, and we have devices that we can feed through those sheaths to actually then address some of the structural causes of bleeding. It comes with a very fancy fluid system. Some of the older systems used fluid that actually was quite dangerous, and you were limited in your time of doing the surgery, and this actually takes away those risks. So what are the structural causes for abnormal bleeding? We spoke about fibroids. Fibroids are a very common growth of the uterus. Up to 70% of women, if we looked hard enough for them, will have fibroids. They mostly don't cause symptoms, but depending on how big, how many, and where they are, they may cause symptoms. And the ones that usually cause the bleeding symptoms are the ones that are submucosal, under the lining of the womb, so impacting on the cavity of the uterus. Ones that are just outside the uterus and are not too big generally don't cause any trouble. They almost never become cancer, so we don't need to remove them if they're not causing any troubles. We know that once you go through menopause, they will shrink down. They never disappear totally, but they may not ever need to be addressed at all. But it's the submucosal ones that we are really looking at. The other structural cause then are polyps. They are folds of endometrium. We don't know why women get polyps. They're very different to colon polyps again. They're not generally associated with cancer or becoming cancerous, but they definitely cause symptoms, and intermenstrual bleeding, discharge are the most common symptoms that they cause. So this is what they look like with the hysteroscope. Again, we're looking through the cervix. That's a polyp, and that's a submucosal fibroid. Just looking at another vein, fibroid, if they were to get that big or bigger, they could also cause pressure effects. So they could press on tubes to cause fertility issues, press on bowel and bladder and cause symptoms. The last one that I do want to talk about is a thing called adenomyosis. And you might have heard it's become a very topical disease because ultrasound people are starting to look for it. We weren't really looking for it in the past. And what it is normal endometrium on an abnormal place. That is the same definition as endometriosis, but this is probably a very different disease. This is a disease in more mature women who have completed their family. However, now that we actually are looking for it, we are finding it in younger women as well. So it is then this endometrial tissue in the wall of the uterus that, under the effect of the ovaries, will bleed, will cause inflammation to the wall of the uterus. And as you can imagine, this uterus becomes then a blood-filled sac, and the pain and discomfort that the woman will have. That is the polyps that we speak of. Just going back to the adenomyosis, so unfortunately we can't get to that with any surgery other than a hysterectomy, removal of the whole muscle of that. Medical treatment, the Marina works very well for this condition. The oral contraceptive pill works well. The tranexamic acid and the anti-inflammatories don't work as well. So this is either hormonal treatment or a hysterectomy. And we're still working on different other innovative ideas because it is becoming more common now that we actually are diagnosing it more. So going back to the other minimally invasive treatment for structural things is the MyoSure hysteroscope. So this is a video of us looking through the cervix into the uterus, and that's a uterine polyp. This device is a small tube with a oscillating blade and a suction device that sucks that uterus, polyp onto the blade, and it sucks it into the uterus, into the device, and removes it. It's Procedure can be done pretty quickly. It's again done in a hospital setting under anaesthetic, but there you have now normal, beautiful cavity with the fibroid removed. In the past, we used to remove fibroids by sticking in instruments, grabbing them and trying to pull them off. We know that up to 25% of those fibroids would recur. It's so much so that one of our colleges have recommended that that be abandoned, and we should only be doing these kind of procedures. So I think it's useful if you were to speak to your gynecologist and say, well, are you going to remove the whole fibroid, or are you going to just pull parts of it off? Because then you do need to be totally removed. The other one is then the submucosal fibroid. So this is what it looks like. This is a medium-sized one, probably about the size of a plum. Again, the metal tube with the suction and then a cutting device that we suck onto it. Sometimes it starts bleeding and we don't see very well, but we'll come back. As I said, the fibroid are these fibrous type tissues. They can be quite hard and it can take a while. Sometimes we do need to go back on a second occasion to go and remove the fibroid. In the past, if we had issues like this, a fibroid of that size would be impossible to scrape out, and a woman would have ended up with a hysterectomy instead of a 7-minute procedure that is very effective. So I'm happy again to field any questions.
Do you have any urine tests before we have any procedure?
Generally not. I'll say generally not. I think most hospitals who do admit patients will screen for an infection, because there is if there's blood infection, we'd want to know about it beforehand. It would depend on your age with regards whether we use the urine test to check that you're not pregnant. So generally in my protocol is for the young woman that potentially could be pregnant, we do a pregnancy test on the urine and they do a dipstick to see that there's no infection. But no, they don't, not routinely, no.
If you've got fibroids and low iron and things like that, can you still get this?
So again, it would depend on where the fibroids were. If they were submucosal fibroids, the ones under the lining of the womb, then this would be a very good option for you. So those kind of fibroids. We can't get you, so you can imagine we're looking through into the cavity, we can't get to that fibroid with this instrument. But potentially that fibroid won't be causing your bleeding. So yes, we would address that. With fibroids of that size, we could do a resection and then an ablation at the same time. So yes, is the answer to a lot of it, but it depends on where the fibroids are.
With the ablation, I'm assuming, is it still possible to fall pregnant after, in the sense of would you need to take some kind of contraceptives to make sure that doesn't happen?
So you are potentially could still fall pregnant, but it's not advised. It's extremely risky. Yep.
Still go on some form of contraception after you've had that procedure, obviously just to make sure that that didn't happen?
Potentially, yeah. Adenomyosis, yeah, it's a difficult.
So that can occur in organs nearby?
No, so if it occurs in organs nearby, then it's called endometriosis. So that, and even though like I say, the definition is similar, it looks like it's two totally separate conditions. So endometriosis then is again normal endometrium on an abnormal place, but it's usually onto things or organs nearby. That is the most common place for it, but it can happen even further than that. It can be in the lung. Men can get endometriosis, extremely rare, and in both cases, the adenomyosis and endometriosis, we don't really know why people get them. There's many theories, and in medicine, when there's theories, it means we haven't got the final answer. But yes, so that is endometriosis, where this is adenomyosis.
And the ablation is recommended for endometriosis, so that's
So again, we're only affecting the lining of the womb. We're not affecting the uterus. We're not affecting outside of the uterus. So it will be for women where we found no other cause for their painful, heavy periods, and in that way can diminish their bleeding and pain.
Endometriosis is easy to find once. Okay.
So that, no, unfortunately, endometriosis is not too easy. We can quickly, let's talk a bit about it, because it's quite topical now, is that unfortunately the only way that you can diagnose endometriosis is an operation. And that's why a lot of people say there's a massive lag between coming for symptoms and actually getting that diagnosis. And it's not because people are nasty or we bad, or it's because you've got to do an invasive operation. You've got to take somebody, and it's called a laparoscopy. So keyhole, camera in the belly button, and look inside. That's the only way you can diagnose endometriosis. And the treatment is very different to this. Then we are talking about excising that endometriosis, so cutting it out with the keyhole surgery. Hormonal treatment does work, the Marina and the oral contraceptive pill will work in that setting. However, they are management of your symptoms. There's no definitive treatment that will bang endometriosis on its head and stop it altogether. And that's the unfortunate thing. So the big, and there is a lot of studies into trying to look at a blood test potentially, a ultrasound or a imaging, that we wouldn't need to take people to theatre to make a diagnosis of a disease that it causes lots of troubles as well.
I guess I fall in that category of not really knowing where to go. I've finished having my family, husbands, sniffing all for fertility. I don't really want to go on. I had been taking tranexamic acid, and I think that had been working well. Yeah, where's my
So the one thing that we sort of spoke about, that stepwise approach of, it would be the pill, the tranexamic acid, and then the MyoSure, the NovaSure at least. And I think, again, going back to investigations need to be done to have a look to say that there's nothing else causing the trouble. Because the NovaSure is such a simple procedure that can be done, you won't be losing anything, and that will definitely decrease your bleeding and decrease your pain. And then I guess it would depend on the different individual, what the potential risk that it might be something else, and whether you need further investigations or not, and that would be a laparoscopy. But in a lot of patients who do come, they've sort of said, well, look, I just need to get on top of my periods and I need a bit of help. Or the other one is, I never want to see a drop of blood in my life again, and then they're the ones who would be inclined to have more invasive surgery. We don't lose anything. The other, even though we said there's a 3% chance that you might end up with a hysterectomy, it doesn't change the way that you do hysterectomies. It doesn't make it more difficult, and so you don't lose a lot by trying something like this first as well. If like say, if you'd completed your family and weren't planning anymore, and were trying to avoid hormones as well. So
adenomyosis, the diagnostics for that, is that ultrasound at the moment?
So suggestive. A diagnosis is you've got to take a biopsy of the myometrium. So the definitive diagnosis again is a hysterectomy. So ultrasounds will say that it looks like that. They've now developed certain things that will say, look, they're suggestive of endometriosis.
Would that be a certain stage of your cycle, or would it?
No, they can throughout the cycle. Yep. They would have a look at it. And unfortunately, not all ultrasound or imaging mode people know this, and not all of them will actually even report on it. So it is quite important, and I use almost women health specific ultrasound providers, because just getting a general ultrasound doesn't always give us the answer. No. And that does lead, to a change in our treatment, because I would generally not offer a woman with adenomyosis the NovaSure. They're the ones who are most likely to continue bleeding, continue having pain, and need something else. In women who want to keep the uterus, I would suggest then the Marina. In women who have completed their family and say, look, I can't anymore, to do a hysterectomy. In that setting, and I didn't really want to go in, but I can talk a bit about hysterectomies have also evolved over time. We talk about a major invasive procedure. However, we now offer a laparoscopic hysterectomies as well, a procedure I do, which is extremely helpful in that the recovery from that is extremely quick. We talk about a day in hospital. Patients go home the following day. They're driving within a couple of weeks. They're mostly back at work within 3 to 4. So it's not minimally invasive, but it's definitely not as major invasive as the old cut hysterectomies, which was 6 to 8 weeks, you know, in your bed, and all the risks involved with that. So we are also evolving other types of modalities treatment, but they're probably not minimal just yet, but a bit, but yeah, and if all of these things, and going back to again, the impact of what what periods have on women's lives is so significant that when we do improve that, they talk about their life after hysterectomy, after ablation, after this. That I think, and that's something that a takeaway that I would like to leave with you guys is that people are willing to suffer so much till they realize that life is better, and we have options here that are non-hormonal that will increase or improve your quality of life significantly.
And what about recurrence of like polyps or fibroids after ablation?
So, because remember, they can recur after ablation. Not so much polyps. We've destroyed the endometrium, so very unlikely. And because we've not destroyed the myometrium, fibroids can occur. They're unlikely to cause bleeding symptoms, but if they were to get very big, they could cause then pressure symptoms.
And are cervical polyps and things like that removed in the same manner as the uterine polyps?
Yes, but having said that, if they are bulging and they're outside the uterus, they're usually done in an outpatient in the setting. Yep.
What caused the post-menopause bleeding?
Postmenopausal bleeding, one of my favorite topics. I guess it's a wide range. So when a woman presents with, so let's take a step back. Bleeding in the menopause is not normal. A period, it's not even a period. Vaginal bleeding in the menopause is not normal at all and needs to be addressed. Luckily, and in most cases, it's not cancer. I think everyone firstly thinks, I've got cancer. And sometimes for that reason, people ignore it, they pretend it's not there, and they delay in care and actually going to go see somebody because they're afraid. But those who do present, what's got to happen then is a risk assessment. They would decide, depending on how far you're from menopause, whether you've used hormone replacement therapy, whether you had issues that we knew about in your premenopause, like fertility issues or fibroids or abnormal periods then, as well as an ultrasound will tell us, do you need further testing? The most common cause for postmenopausal bleeding is a lining of the womb that's actually too thin. That because there's no more hormones, the endometrium is thinned out to a point that there's a bare area that bleeds from there. That's the most common cause. It's benign, it's not a cancer. But those who have a thickened endometrium or have any of those risk factors that I spoke of, we need to then go have a look inside. And in that setting, usually the most common cause is a polyp. Next most common cause is we call it hyperplasia, just thickening of the endometrium. And about 1 in 10, probably to 1 in 15, it will be a malignancy, a cancer. The good thing about endometrial cancer is that it presents early. If you do come for that first bleed, we normally pick it up early, it's easily treated, and you recover very well from it. So it definitely is a symptom that shouldn't be ignored. The most common reason for it is not a cancer, but if we can treat it, pick it up easily, it's easily treatable.
Is there any symptom before the bleeding?
Sorry. So I guess if I understand your question, are there any symptoms or anything about the bleeding that characterizes what causes it? Is that what you're saying? No, unfortunately. So some patients come to me and say, I've just had a bit of pinkish discharge. I've just had a spot of blood. It wasn't like a period, and unfortunately that doesn't mean that it's not a cancer or it is this. the type of bleeding does not distinguish whatever the cause is in postmenopausal bleeding. So bleeding in menopause is not normal, needs to be evaluated, not always a further investigation, because sometimes a thin ultrasound will show a thin uterus, you don't have any risk factors, and we can not have to do anything further.
So if I have a small fibroid, would that cost?
Probably not. Probably not, is the answer. It's probably just a coincidental, innocent little fibroid that's been sitting there, probably been there for most of your life, and doesn't need to be addressed at all. Sure.
The bigger the fibroids, like looking at that, like one on the top.
Yep.
So during a cycle or something, obviously inflammation in the uterus or whatever, can that have more impact on like bowel and bladder? Like
Yes is the answer. So correct.
during that time of
Yep,
the month,
yep,
you know,
yep.
having more impact on things around it,
Yes.
pressure-wise and that kind
Yep.
of thing.
No, that's true. Having said that, that's not a big fibroid. I did a hysterectomy. I delivered a baby. It was 3.3 kilograms, the uterus. It was about that big. That's a big fibroid. So something about I'd say 2 to 4 centimeters are common, and usually don't cause symptoms unless they are below the lining of the womb, and probably don't need to be, unless, like you say, you're getting cyclical pain, pressure on your bladder, pressure on your bowel, things like that, then we would talk about a treatment. We can address those ones laparoscopically through, again, keyhole, and then remove it through that way. We obviously can't get to these ones laparoscopically, or that one. We probably wouldn't even be able to see that, whether we were looking from the outside or from the inside. And something like that usually doesn't cause any symptoms and doesn't need to be addressed at all.